Hello, everyone. Welcome to another edition of the ASMBS Bariatric Happy Hour. I am delighted to say that we are having our second in a series of two tonight, talking about the ESG. This will be the video edition. We have one of our more prolific gastroenterologist joining us tonight. And on the panel, we also have Dr. Jain-Spangler, Dr. Dan, and Dr. Pantelis joining me tonight. We will only do a couple announcements. As you guys know, ASMBS has the First Fridays, the fellow project that's happening next month. Also at the beginning of January is the extended deadline for ASMBS conference. If you guys have abstracts, please remember to submit them. It's due on the 4th of January, so keep up with that. But without further ado, let me start with a biography, talking about Dr. Abidi, Wasif Abidi. He earned his MD PhD from New York University School of Medicine. He did residency training in New York at Mount Sinai, and then he completed his fellowship at the Brigham and Women's Hospital in Boston. He did a gastroenterology and advanced endoscopy fellowship there. He then went on to do a bariatric endoscopy fellowship, and he got some great experience, and he'll be talking to us today about endoscopic suturing and talking about ESG technique. He most recently also received a STAR Award and teaches bariatric courses in endoscopic suturing. So I think it's great for him to talk to us about the ESG. We're also joined tonight by one of the fellows, Dr. Pantelis. So he, wait, are you a fellow? I thought you were a fellow.
I just completed my fellowship.
Oh, okay. That's what I was like. Oh,
less than a month ago.
Okay. Well, sorry about that. Dr. Pantelis hails from Greece. He graduated from medical school in Athens in 2007. He carries a master, actually two master's degrees from doing research in thrombosis, hemostasis, and transfusion, as well as trauma. He became a board-certified surgeon in Greece back in 2018 and very recently completed his fellowship in metabolic and bariatric surgery in India. We're delighted to have both of you guys here. I feel like I'm talking a lot, and I would love us to start talking about ESG. So I'll turn it over to you, Dr. Abidi.
Thank you so much for that kind introduction. I have to say I cheated a little bit. At the third year of my GI fellowship, I actually ended up doing my bariatric fellowship, so I saved a year there, and it was very nice. It was a lot of fun. So I've been tasked with talking about the endoscopic sleeve gastroplasty, and we've done quite a few of these here at Baylor, and I've been involved with a lot of courses and teaching this and doing some of the I've done some of them. Some of the initial ASGE courses teaching the advanced suturing and the bariatric suturing courses. So happy to be here, and I love teaching this. It's great. Just some disclosures. I do have research support from GI Dynamics, which makes another weight loss device, and bariatric metabolic device, endoscopic. And I'm a consultant for Apollo Endosurgery, and we are going to be talking a lot about their device, the Apollo Endosurgery device. They make the overstitch device. So this is a very sophisticated group. You guys know that diet and exercise is under the cornerstone of all weight loss programs, but that doesn't really work for everybody. And there's a lot of weight recidivism with people losing and yo-yoing. So we need some tools, and the standard tools that people really think about are the medications and surgery. And medications, maybe 5 years ago, really didn't have as much of an exposure, a lot of side effects, not as much weight loss. Nowadays, that they've really become a great adjunct part of our weight loss regimen, and people have lost quite a bit of weight on some of these medications, although they do have some side effects, so you have to be careful with those. Surgery, you guys are the surgeons, you guys know surgeries more than I do. They work really well, but they're also invasive, and we know that only about 1% of patients who should get the surgery really do get the surgery. So it's definitely underutilized, and so that's where sort of endoscopic bariatric therapy is kind of into place. These are procedures that are not as invasive as surgery, but they still work really well, and they may not have some of the disadvantages that medications have. And at least it's worth developing this area and having another area and another option for patients. So what do I talk about when I talk about endoscopic bariatric therapies? Just taking kind of a bird's eye view, first of all. This includes the intragastric balloons and the endoscopic sleeve gastroplasty. Those are the major ones that are currently offered. There are some small bowel therapies that are not really being offered right now. They're not FDA, or they're FDA approved, but they're sort of in their early phase. The duodenal mucosal resurfacing and the endobarrier device, and that's what GI Dynamics makes, and we're part of a trial to get this approved in the US. Balloons, they've been around for quite a while. I don't know if you guys, any of you have been around or heard about the Edward Garrett's balloon, which was a sort of a cylindrical shaped balloon in the 80s. It was horrible. It was sharp. It burst, and it would cause obstruction. It would cause ulcers. It caused perforations in the stomach. So it got taken off the market, and America's appetite for balloons was really lost for quite a while, and we got them back in 2015. But in the interim, this Orbera balloon has actually been around around the world since about 1996, and there's a lot of good data on it, and it works. But it has some disadvantages, and honestly, those patients they have a lot of nausea, a lot of symptoms, and I don't really like taking care of those kind of patients all the time. But we're going to be talking about the endoscopic sleeve gastroplasty. So this is a restrictive procedure, which entails gastric volume reduction. And really, it's our version of trying to create a sleeve gastrectomy. But we can't, of course, take out the part of that stomach. We just basically suture down and plasty it and suture it down and reduce the volume. We use an overstitch device. This is what I was talking about, the Apollo endosurgery. This really is one of the few available, this is the only available suturing device. There are a couple other devices that are currently being available, that are kind of coming into the market. I'm not going to go talk about them just because they're not widely available yet, but there are some alternatives to this. This is used on a double channel endoscope, and it really had that handle that you saw. And then there is a wire, an actuation wire that gets to the end with an end cap that helps you put in the sutures. This device is a little bit complicated, and it takes a while for both gastroenterologists and surgeons to kind of take a little bit of time to really get used to it and to understand how it works and get it to get you really troubleshoot it and things like that. So it takes a little bit of training. It takes at least 25 cases for you to be really competent in it, or at least get the basics of it, and then probably another 25 before you really get good at troubleshooting and knowing what you're doing. But this device essentially is our way of working from a meter away and being able to put in sutures, full thickness sutures, into the stomach or wall, or any other wall for that matter. And so you can see here, there is a needle driver, and that's kind of the needle driver. This is the needle itself. And the needle itself is kind of actually an anchor. So it has the suture attached to the needle, but not at the end of it. It's in the middle. So when we let go of that needle, it becomes an anchor, and it becomes like a T-tag. And the suture is across there. This part is essentially our grasper. It's a needle exchange, and so it allows us to grab the needle once it goes through tissue. So we'll just see this. It's loaded onto the needle driver. And then you, of course, need to be able to bring tissue to ourselves and really get full thickness tissue. So you have a helical retractor, and that's able to pull onto that tissue and get a real full thickness bite. And then you can kind of see here, the device is able to drive that needle through the tissue, and then you use this exchange to pull it off, and now you've made a full bite. You get out there, get the driver out, and you've made a full bite, and you're able to get through tissue and do what you need to do. And this device is approved, honestly, it's just approved for tissue approximation. It's not necessarily approved for bariatric procedures. It's not approved for bariatric dealing with complications of surgery. Anything, you can do it for anything. I've had a sleeve that's completely opened up because of issues with the a sleeve gastrectomy that's completely opened up because of issues with the stapling device, and I've gone there and sutured it one piece by piece and able to bring it all together. But even post polypectomy, post ESD, post POEM, we'll do a lot of closures. We'll use the suturing device just because it's able to really bring and approximate tissue easily. This is just some world expert known as me. Just kidding. This is one of the early videos that I created, and just shows you kind of going back and forth and all the steps that are involved. It's not exactly intuitive because you're kind of doing this handle, you're doing this button, you're going in and out. So that's what takes a little bit of while to learn. But now getting to the ESG itself. So the ESG, so this is the device that we're going to use, and we're going to be putting sutures to reduce the volume of the stomach. The way there are people who do it different ways. So I will give that caveat that we haven't figured out exactly the best way of doing it. But one of the simplest ways that we are this is the way that we teach. This is the way the merit trial was done, which was a randomized control trial. First APC markings are done, or cautery markings are done on the anterior and posterior margins of the greater curvature. Sorry about that. And once you've made your markings, you kind of get yourself an assessment of, hey, this is the area that I need to bring down. So I'm going to go ahead and bring this down. And then you start with the U pattern. You start at the incisura or across the incisura, and you start with the U pattern. And you kind of go from anterior to posterior, and then you kind of come to posterior, back up to anterior. Notice that this is actually showing it a little bit of a different way. It's fine. People actually will go anterior to posterior, then anterior to posterior. And then once that's down, you'll suture that, you'll tighten that down, and then you'll put a reinforcing suture across that. And then once you have that area done, then you'll work from there. You'll work more proximally and be able to continuously bring down the stomach and fold it down. All right, so enough.
So actually, can I interrupt you 1 sec? Can you go back to that slide? So you mentioned something on here. So how do you decide where to make your APC marks? Like what you mentioned the incisura, but what other landmarks are you using in terms of
like? I'm going pretty much anterior and fully anterior, sort of as anterior as possible and as posterior as possible. Pretty much taken over 180, at least 180 degrees of the greater curvature, and that's where I'm going to put my markings. It's not, these markings are not 100% where I need to go. So I may decide, hey, I like these markings. This is where I'm going to be. It's really to give yourself a little bit of you can get lost with all the blood that happens in there, with your kind of moving around, trying to get the suturing in the right spot. You can get lost about where exactly your landmarks are. Those are just to give you an idea of where you need to be and where the anterior is, where the posterior is. So I'm using greater curvature, lesser curvature, and then I'm kind of going right between them, and I'm doing my anterior and then my posterior markings. Okay. Other thing is to avoid the fundus, and we'll talk about that as well. There's data to show that you really want to avoid the fundus. All right, so let's look at it in a real patient. All right, so the first thing, of course, is I assess the anatomy. I see what's going on, take a look, clean it out, make sure I don't have this big ulcer or some problem or sort of submucosal lesion or something that I have to evaluate a little bit better. This is the APC. It's argon plasma coagulation. So just, I don't know, have you guys used this at all? Or do you guys use anything like this at all? Yes?
People who do a lot of endoscopy do, otherwise no.
Okay, well,
So those of us who do like stoma tightening and stuff like that will have used it, but otherwise not.
Yeah, of course, for stoma tightening, you're going to use that very clearly. But just for anyone who may not be familiar, it's argon plasma coagulation. Is an argon gas that's going through this catheter. There's a wire in the middle of the catheter. The patient is quote unquote grounded or has a return pad, and so the argon is able to there's an electric arc that goes through the argon and basically creates this plasma, and it burns it takes a relatively superficial burn. And so here's the anterior along between the greater curvature and the lesser curvature, and there's my posterior marks. And I kind of get myself an idea of, hey, this is where I'm going to be. And maybe the posterior was a little bit too high, but it really is, it's not that big of a deal, and it's okay. And then there's that arc that's created with the argon plasma coagulation. Honestly, I have the most fun doing APC. And it's just like this nice laser kind of like, I feel like I'm a Jedi or something. All right, and so then you have that arc that you've created across so this is, sorry, I didn't mention this. I'm going to go back through this again. This is different than I just mentioned. This is what I have done as a little bit of a change from the standard protocol. I will use APC on the other side of the incisura, and the concept of this is the same way that we do with stoma reduction, where you need to ablate the mucosa and suture it in, and you're hoping that when it heals, it'll heal at a much more stricter level. And so that's the same concept that I'm using with gastroplasty. And there's some people that are a lot more aggressive with it and will APC a lot more of the stomach. But one kind of line across from the incisura is enough for me, both to get my idea of where exactly I'm going to be going, and I'm hoping that this area creates a stricture. And I've been into patients' stomachs, a month afterwards, and it really does create a lot of nice scarring in that area, and it really comes together really nicely. And here's the sort of the anterior markings. I'm sort of making, I'm not going to make this line of a marking just because it takes too much. I'm quickly just going to kind of just touch it in that area. You notice that you really do need to kind of look back. You always need to kind of come back. You need to be able to look at where you're going on. Right there, I kind of see, hey, that looks like a pretty good area. I'm really happy with that. I'm going to continue down. And I may not stick with this. I might be a little bit more aggressive, go a little bit outside it, because I say, you know what, the stomach's not getting small enough. Let me go a little bit more further up and further down, or you know what, I'm going too far and it's getting a little too tight. I'll adjust to where I'm going to be, but it just gives me an idea of where it initially started. And so you can see here, those are the markings that I eventually made. I made it along the anterior there, along the posterior as well. And you may notice there's another third line that I make along the middle, essentially between the two. And that gives me an idea to kind of make sure that I'm not making too many bites early on or too many bites later on, or I'm not, just to kind of give me an idea of where I am with the whole thing. This is somewhat optional. You'll talk to some people who would be like, no, I don't really need to do it. It doesn't take that long, so I don't think it really takes much time at all. It takes about 2 to 3 minutes just to do all those. So for me, I go ahead and do it. It's a good safety backup just in case you kind of need to get your bearings down. All right, so this is putting the device, loading the device. You kind of run a test cycle just to make sure it's working properly. And then we're just going to start with that sort of distal suture right at that area that I've APC'd. This has been sped up 2x, just FYI, just for full disclosure, just so that we're not sitting around here forever. And you can see that I am making pretty good full thickness bites. I'm pulling the tissue to myself. So where's that helix again? Pulling the tissue to myself and really getting the tissue so that I'm getting almost a pink out, or in this case, a brown out. And that allows me to really make a nice full thickness bite. And when you use this device, you also kind of get a feel for the amount of resistance that's going through tissue. If you're not making a full thickness bite, you're not going through muscle, it feels like you're just going through water. It really doesn't feel like any resistance at all when you're closing that handle and driving that needle driver. All right, so you kind of you can see that I went from anterior to posterior. I do a single line initially, and then I'm going to do a U pattern after that. So again, no one's really shown. In fact, there are people who've shown that the pattern that you do doesn't really matter. This is the pattern that I feel comfortable with, so I keep doing it, and data's pretty good. It's still right at where everybody else is going. It's about 15% total body weight loss, so I'm not too worried about this. But you can see here that here's that needle that I dropped, and it's acting here as a T tag. It's not getting buried into the stomach because the suture comes right off the middle, and it's able to act like a T tag. And then the other side, we can't really put a knot down or anything. So what I'm going to do is I'm going to take a cinch down, and you're going to see that. And that's how we tighten that suture endoscopically, so that we don't have to put any more devices in there. And there's that cinch, and then I'm pulling on this suture and really tightening this down, and you can see the whole stomach coming down, not just because I'm suctioning, but also because I'm able to pull that down.
So it's almost like you do a purse string for your first bite. So you said it's all in a line, right? And then you pull everything together.
It's like half of a purse string. It's half of a purse string, essentially. A purse string, I would have gone all the way around. And I've heard some people have done an actual purse string right at the incisura. I just feel like that's a little bit too aggressive and too many bites. And I don't want to really grab anything on that lesser curve and try to grab into the liver or anything like that.
How do you gauge when you've pulled down enough of the tissue? Like the right lumen size?
Good question. There is no lumen that's too small. So even a lot of this is edema. A lot of this is will open up a little bit. And actually, I would say that this is too big. And I looked at this, and I did think that that's too big, because my next bite, I didn't go back down here as you might do if you're kind of away from that line that you would start next to you. I actually started very close to where I was working already, because I said, you know what, I need to bring this down a little tighter. I need to make it a little bit smaller. And so I will go very close to where I was working already, go a little bit more aggressive and say, okay, good, I'm going there, and that will hopefully bring it down. And when you'll see when I suture down and cinch down this this second suture, it will get a lot smaller. And it's the same thing. Many people have said it, that if it's almost, you rarely have any issue where someone really cannot eat anything. In the trial, that randomized control trial, they did have one person who was having malnutrition, so they had to reverse the gastroplasty. They just couldn't eat anything. I've had one patient who was I had to take a suture out right around that incisora area because they just really couldn't eat too much. But it was a different scenario. He could have been fine the way he was. He was just really low energy, and he had to be on national TV. So he was like, I need to be on TV. I need to have energy. I need to do things. Can you just take one suture out, and we'll figure out from there what to do. Of course, he comes to me later and is like, I'm not losing enough weight. And I was like, of course you're not going to lose enough weight. But generally, doesn't matter how tight you make it. They don't have many major. They might have a lot of difficulty early on, but eventually they'll manage.
When you're doing the APC at the incisor, I mean, do you, or I guess in general, anywhere in the stomach, do you ever do an injection first, kind of to create a wheal, a submucosal wheal or something, so you don't get or burn too deeply?
No, I don't. I don't find so the stomach's pretty thick. It's not too much of an issue. I don't feel like I've had any complications. I haven't had anyone else who've had complications. It's a lot of area that we'd have to inject to kind of protect the muscle. We do that for anti-reflux mucosal ablation when working sort of in the cardia area. We do make a little bit of a cushion and then burn into that cushion to avoid any muscular injury. To be honest, I'm not even sure for that case we really have to create that much of a cushion for stoma reduction. We don't really do that. We don't really make any cushion. At some level, there's a theory of no one really looked at this on pigs or anything, but the theory is that you do want some of that muscle burn, so you create some scarring in the muscle itself and cause it to contract when it heals. All right, so we're on the second U. We've done the second bite already, and we're going to the third bite. We're kind of taking this U across here from anterior to posterior. Again, the same thing. You're really kind of almost doing a pink out when you're making sure that you're really getting good full thickness bites. There are times, and you can see that here, there are times you have to be really careful to make sure that your sutures are not crossing. Despite the fact that it might be look like I'm crossing, I am being very careful not to cross the sutures that I'm working on. So I've made the anterior to posterior already, and now I'm going posterior to anterior. I kind of changed my angle just a little bit, and the reason is because, let me go back a little bit. The device kind of goes from the right upper area, sorry, the left upper area to the right lower area. And so your sutures are going to be kind of a natural line when you're doing anterior to posterior, because you're kind of going boom, 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 and going almost in a straight line. But when you start going posterior to anterior, if you stay in this configuration, you're going to be doing a lot of loops, because you're going to be going from past anterior to posterior, and kind of that's where your needle driver is going to go in. So I try to put a little bit of an angle when I'm working on the other side. Oops, sorry. I start to make a little bit of an angle when I'm working on the other side so that it's not completely sort of looped, and it's not going to make it difficult for me to pull that suture at the end when I'm trying to pull it along the whole U. You can see the whole device is a little bit angled, and it's a long sort of, and sometimes I'm going all the way completely turning around. There is risk with that. You have to be very careful with the sutures. Make sure you don't get that suture tied in. You don't want to get that suture tied in. You don't want to get them crossed. I have gotten them crossed before. It's a pain. You sometimes have to just start all over again, or you have to do some crazy measures to try to get them to be fixed. Okay, so we did the U. When I do my U, I am being careful to kind of make the U far apart, kind of like, so it's a big wide U. And what that does is it not only brings down the lumen, but it also shortens the lumen of the stomach. And that's one of the measurements they made in this sort of randomized controlled trial that they had to see if this device worked. And you can see now I'm a lot happier with that opening. That's much smaller. That's kind of where it needs to be. It's still going to open up when the patient kind of heals and some of this edema dies down, but at least it's a little bit more comfortable for me. It's about 10 millimeters, maybe a little bit less, and I'm comfortable with that. So now I'm going to make another reinforcing eye to get that to be to stay down. I am not showing you all the bites anymore, so I'm just going to show you the cinching, and you can see that the sort of this tubular stomach is starting to form, and it looks pretty good. And there's another U that we're kind of doing, and bringing and cinching that down to bring that kind of to create that tubular stomach. And so we're going to probably do another eye, another line to reinforce this U, and then that starts to get into that fundus area, and I try to avoid the fundus. And the reason I'm avoiding the fundus, there is data to show essentially that suturing with fundus or without fundus, really they have the same amount of weight loss. They have there are some earlier data that showed that it was that it had more complications, but the most recent random it's a multi-center trial, it's like 250 patients. It showed that there wasn't any difference in complications, but it took a lot longer. So you spent a lot more time kind of messing with that fundus and trying to get it all down without any benefit. You're not having much of a change in weight loss, so it's just not worth it. And so here's the final tubular stomach that you're looking at, getting into the antrum. So the antrum looks great. You're going to come back. This is that tight incisura. I want it to be a little bit tight, but be able to still get the scope down. And then you can see that tubular stomach there.
You know, that's very interesting what you mentioned about the fundus, because surgically, that's probably the most important area for us to narrow. So, you know, this is completely different. So you're mostly working like in the body.
Yeah, we're mostly working in the body. At least for now, we have data. Like I said, we don't know the exact pattern that should work. For all we know, in a few years, there's going to be more data come out that shows you really should have worked on the fundus. I will tell you from experience, and talking to other people, a lot of surgeons who do it will focus on the fundus because of that exact training. They'd be like, oh no, we need to really bring down the fundus. We need to bring down the fundus. But based on some of the earlier data showing that there was some complications, the more recent data shows no difference in complications, but there's no difference in weight loss. We don't really find that's absolutely necessary. It is also a difference in how I sell it to the patient or talk to the patients about it. I will tell them, look, you are getting a procedure that is going to be that is not as invasive. It's not as strong as a sleeve gastrectomy. I can't do what a surgeon can do. I will help you lose weight. It's a tool. You will have a reduced satiety, but your stomach is all still there. I can't take away your stomach. So if you wanted to eat like a double cheeseburger with a large fries and a large Coke, you could still do it. You're going to hurt because all those sutures start pulling on things, and people do hurt, but they can fit in their stomach. They're like, you know, why can't I fit in the stomach? Because your stomach is all still there and the fundus is still there. But the point is you start listening to your signals, and you start listening to signals of your body saying, look, I don't need the food. I don't have that appetite. You know, I feel full. I'm okay. You can stop earlier rather than compared to what you're used to. And those are the kind of lessons that I want the patients to go and stay with, and realize that after the effects of this thing are worn off, you're still habits and really try to keep the weight off.
You froze up for a second there at the very end.
So I don't know where I froze, but essentially I tell the patients that, look, they're not, you're gonna, you know, I want them to learn from the difference in feeling that they're gonna get, and that I want them to eat less. I want them to notice that they can sort of not have as much of an appetite, and they'll be fine eating the smaller amounts. Get used to those habits. And then, you know, the effects of the sleeve are going to wear off. The sleeve gastroplasty are going to wear off eventually. We think, you know, maybe 2 years, maybe 5 years. We have data out to actually 2 or 5 years that are good, but still it will wear off eventually. And I want them to kind of keep losing weight at that point in time. Okay.
I still have a bunch of questions, but I want to give other people
Oh,
a chance. I want
go
to
for it.
jump in. Okay. So you mentioned that you do about 6 to 8 sutures. You know, how long is the segment of the stomach that you're constricting or suturing down?
So it's that segment. So I'm going from the GE junction to the incisura. I measure that, and it's usually about 17 to 20 centimeters initially. Once I'm done with it, that ends up being about 7. It reduces by about 10 centimeters. So it's about 7 to 10 centimeters when I'm done with it. I don't like measure. So I think in some of the trials, they measured from all the way from the pylorus, but that involves a loop and it's hard to really measure with the loop. So I really like to kind of measure from the incisura to the GE junction and get that area. And it's sort of the distal extent of that incisura that I'm comparing. So it is about a 15 to 20 centimeter area that I'm making smaller and making more tubular.
And you mentioned sometimes that the sutures sometimes can get crossed. If that happens, like, how do you maneuver? Like, do you completely remove it?
I have a whole 1 hour like presentation on what to do when things go wrong with this device, because a lot of stuff, every single component can have its problems and can cause its issues. Cross sutures is a big deal. Once you cross the sutures, the biggest thing is you have to recognize it initially. I have a video. If you guys are okay with it, I can pull up another video of a cross suture and kind of how I undid it. But it's going to take a little bit of effort. But basically, you're going to go back and forth on the device and basically exchanging it and seeing how it might be crossed. Let me see if I can.
Yeah, so you know, this device is similar to the Endostitch in that it has a needle that is connected to the suture in the middle of the needle, and it toggles back and forth the same way. And definitely when the Endostitch gets the sutures get crossed, you can kind of toggle back and forth to release it too.
Yeah, there's also rotation that you can do. So I can't really, I think it was after this that it was. Let's see here. So, I mean, this is crossed, but I'm going underneath it and I'm working on one side of it, so it's not a big deal. So you don't have to worry about that. You're not a true cross. I think at one point I do get a true cross here. And there's fine as well. And then you go a little bit further in. And this is where I think I get the true cross. Shoot. So basically right there, you can see it is crossed. And if I grab the suture at this point in time, I'm sorry, but if I had grabbed the suture at that point in time, it would have been a problem. If I grabbed the suture at that point in time, it would have been a problem. And so instead I kind of rotated it so that this suture was on the other side and then grabbed it underneath to allow that. So you have a little bit of a rotation ability so that you can grab underneath it or grab over it. There are times when you can get it not just crossed, actually tied in there. And I've had students who've tried to do this and they actually will put a knot in there. In which case you have to see where the knot is going and essentially put this device through the knot and grab on the other side.
Oh my God.
Undo it. So it's whatever you need to do. You really need to have that 3D spatial kind of understanding of where the sutures are coming, what the leading suture is, what the trailing suture is, and being able to kind of undo it at that point in time. You can also just, if you're crossed, you can also just rotate this, and because it's more flexible than the Endostitch, so you can rotate it a lot more, and be able to kind of work around the fact that you're crossed at this time, and then go from there. And of course, if you fail completely or if you lose your patience, just cinch it down. and then continue working with a new suture or redo it, do whatever you need to do. Cut it and redo it if you have to.
We have a couple questions in the chat. The first one is asking about
Any other
rates.
questions?
What's that?
Oh, you're frozen.
Oh, can you hear me?
Yeah, I can hear you now.
Okay. There are a couple questions in the chat. The first one is about de novo GERD with ESG.
Yeah.
And the rates are actually lower than with sleeve gastrectomy. Why do you think that is?
So it's not as restrictive as it is with the sleeve gastrectomy. I know a lot of people and we don't know clearly we don't know the mechanism. We know that it causes less GERD. There's very little GERD with the sleeve gastroplasty. But we don't know the exact mechanism of why. We are avoiding the fundus in general. So that is one possibility where we're kind of staying away from that GE junction. I think the one person who did have GERD with my patients, I had gotten pretty close to suturing around the GE junction. And I don't know if that was part of the reason why she may have gotten some GERD. And the other is it's just not as restrictive. We are reducing the volume of the stomach about 20 to 30% based on the studies in my estimate. And I tell patients it's probably around 30 to 50% once this is all healed and kind of gone immediately. Yeah, sure. I'm 20 to 30% of what I used to be, but I'm sure it opens up eventually. Some of the edema dies down and some of the sutures come through. And it's, I tell them it's about 50% of what it used to be. And the sleeve, obviously your sleeve gastrectomy is much more restrictive. And you can have a lot more GERD because of that. And I don't know if it's because you are working very close to that angled hiss as well. And you can kind of, you may be messing with some of the mechanisms of the G junction in that way. I know there are surgeons who avoid the fundus completely, and so they start their sleeve a little bit further down. But I've had their patients also come to me and say, "Look, I have tons of GERD and tons of problems," and you go in there and you take a look at it, and it's a very restrictive sleeve, and they're really not able to get anything down the sleeve.
You can go ahead.
Okay.
Sorry.
So yeah, I mean, if there are any questions, anybody has any questions, go ahead. I just showed another one. This one is sped up a little bit more. I think it was 4x sped up, and it's just another example of a endoscopic sleeve gastroplasty, just to get an idea that, hey, this is, you know, what another one might look like. Similar issue where a similar approach where I'm doing APC. I've already burned it here, and now I'm doing my suturing in a line, creating that sort of half of a purse string, bringing down all that to the level that I wanted to do. Here, this one became a little bit tighter, and I'm happier with that level of tightness, actually. There's that tightness that was there before, and then the U pattern here for the next one. And eventually that's all I'm going to show essentially in terms of the suturing. But you can say it takes a little bit of time to really bring this all down. You really have to take your time, your patience, and allow that suture to kind of run its course. Because if you tighten it too quickly, you're going to leave a lot of it open and a lot of it loose. And here again is a nice tubular stomach, you can see here, avoiding the fundus, but going all the way down to the incisura and creating a nice small stomach.
Go ahead, Dr. Pantelis.
Yes, thank you very much. I would like to ask a couple of questions, mostly from the fellow's perspective. One is about the mechanism of the procedure. There was a recent publication by the same group as the one that published the MERIT study about the hormones. And they found that there is an increase in ghrelin and GLP-1 as well. Increase in ghrelin makes sense because the fundus is there, so it secretes ghrelin.
Some of their older... Go ahead.
But the increase in GLP-1 is a little bit counterintuitive because there is a delayed gastric emptying. So what do you believe is the actual mechanism? Is it the restriction? Is it the delayed gastric emptying? Is it something else?
So they have So I think the jury's out in terms of the hormones. We don't have the data yet. I mean, even with the gastric bypass, how long did it take us to figure out all the hormones and everything? So I think the jury is still out there. Some of their earlier, this is actually one of their earlier studies in 2017, looking at 25 patients, obviously less patients, but they had gastric emptying is almost without a doubt is reduced. You're going to put all these sutures in there. You're going to mess with the mechanism of motility of the stomach. You're going to reduce the gastric emptying. Satiation is also increased, and they show that in color. And this is 3 months post. In this study, ghrelin levels decreased by 30% from whatever they saw there. That's what they kind of clear as see. I mean, ghrelin levels are it's still not clear. You know, you do some of these sleeves and the sleeve, the amount of ghrelin that's reduced is not really directly proportional to the amount of, the amount of stomach that you're taking out. So there's a lot more to ghrelin than I think we really know about. But there was another study by Lopez Nava that in 2020 that really showed that ghrelin did not decrease, and the more recent study showing that ghrelin increased. So I think the jury's out with a lot of these hormones in terms of where it's going, what side it's going. Is it going up? Is it going down? Lopez Nava's group, they say ghrelin didn't really increase. That it kind of stayed about the same, which is good for someone who is losing weight, for them not to increase their ghrelin levels. They don't really see any changes in peptide YY and GLP-1 from what I remember. But I think it's a little too early for us to know some of the absolute details of how this all works. And I think once we've gotten this a little bit more kind of approved and a little bit more established, people will start, it's worth making some kind of a mouse model or something, and studying it in a more controlled fashion and seeing exactly how the weight is lost and what hormones are changing, so that we can get a better sense of what to do and how to do it. And that's essentially this next slide. So that's perfect timing on that question. It's almost like I planted it. So this is the MERIT trial. This is the prospective multi-center randomized trial that was sponsored by Apollo itself. And what they wanted to do, essentially, they had a device that was approved for approximation of tissue, but they really wanted to sell the fact that you could get people to lose weight with this, but they couldn't, because they didn't have the FDA approval for it. So they put it in a kit and they said, okay, here you get 8 sutures, 8 cinches, you get the device, and you get, all the sutures that you need and everything, and the helix. And we'll send this kit, and we'll get this kit to be FDA approved, but we need a randomized controlled trial showing that it works. And so they looked at patients. This was at 85 patients that had ESG plus lifestyle modifications versus lifestyle modifications alone in 124 patients that was randomized 1 to 1.5. Ratio, and the patients had a BMI of 30 to 40. I didn't really talk about where we're which patient population we're targeting. I'll talk about that a little bit later. But these patients, most of us are really looking at that 30 to 40 BMI sweet spot. So not as sick, not as obese for the patients that need surgery, but at the same time, they may not be approved for surgery, and so this is kind of right in the middle area. And so these patients, they lost weight. You can see primary ESG. This is total body weight loss, around 15 to down to 13% by 12 months. And this is compared to the control on the red, and this is the primary control getting lifestyle alone. At 52 weeks, they had a crossover. So the people who had lifestyle modifications alone got the ESG, and you can see that they also responded pretty appropriately. And the primary ESG group continued to keep their weight off. Just as a caveat, and I'll admit this, that some of these patients, it was about 6 of the patients that got the ESG did have a retightening. If they didn't have enough weight loss, or if they felt like that that the patient wasn't getting enough of a restriction, they could go in there at 52 weeks, take a look, and potentially retighten that sleeve. But it wasn't that many patients that got a retightening. So there. Go ahead.
Sorry, I was just going to jump in and ask you another question that's in the chat, but you can go over the slide. We did talk about the MERIT trial last month, so put this a great summary or a reminder.
All right, so then you guys probably know it just as well as I do. Excess weight loss of 49% versus 3.2%. Total body weight loss 13.6%. And then at 104 weeks, 68% maintained a 25% excess weight loss. So that 2 years, quite a few had maintained some of that excess weight loss. I tell my patients, I'm telling, there are some older data that shows that people had a 15 to 20% total body weight loss. These are patients who are more vested in. These were not patients who were getting this procedure for free. And so 15 to 20% at 5 years, actually. Some of the data goes out to 5 years. So I tell them to expect somewhere between 30 and 20% total body weight loss, with about 15% a good sort of estimate of where they're going to be. Of course, some people are going to do much better than that. Some people are going to do a lot worse. Adverse events. So the patient. So you've gone through the MERIT trial. So I don't have to go into this too much. But abdominal pain. Almost all my patients do have quite a bit of pain after the procedure. It lasts about 3 days. It's almost like clearly at that 3rd day mark, they're like, oh, I'm pretty good. That first day is pretty brutal. And then 2nd day, 3rd day, it'll calm down quite a bit. And they do quite a bit better. They do have some nausea, vomiting. I do give them a liquid diet after the procedure. I'm potentially a little bit more aggressive than a sleeve gastrectomy. I try to put it out to 3 or 4 weeks. And my reasoning to this, and I tell the patients, look, you had a procedure that wasn't as aggressive. It's not as strong as a sleeve gastrectomy. So you really need to treat it gingerly, let it heal, let it do what it needs to do. And so try to be on a liquid diet a little bit longer. But generally, I think most people will do about for 2 weeks of a liquid diet and then go to soft foods and then solid foods after that. Rare adverse events, bleeding. You're putting sutures through tissue. You're going to get bleeding. So some of these are full thickness. So you're going to get bleeding not only inside the stomach, you're also going to get a perigastric hematoma. You can get fluid collections from leaks that come from the outside. And then you can also have trauma to surrounding organs. I was going to mention it. I don't remember if I did mention it, but when I'm putting a lot of these sutures that I put in there, I really am pulling the stomach to myself. You're not pushing the scope forward to try to get that bite. You really are pulling the stomach back to you. And you'll know when your helix has gone too far. When you've gone too far and you grabbed into abdominal wall, or you got into some kind of organ or something, it just doesn't come at you and it doesn't come to you. And you're like, ooh, I went a little bit too far. And you've created a little bit of a hole in there. It doesn't usually cause any issues, even for patients who have to be on anticoagulation pretty much like hours afterwards. There rarely is any major like bleeding or anything like that, because suturing itself and cinching itself will control a lot of the bleeding. But it is something to kind of consider. And so, yes, I'm always telling people just work from far away and bring the tissue to you so that you're not grabbing something from behind. So some logistics. This is mostly a cash pay procedure. So at this time, at least, the cost of it is about $9,000 to $16,000. 9,000 is probably a little bit on the lower side. 16 is some of the more academic centers will be sort of in that 16,000 range. I've gotten about 30 to 40% insurance coverage, and that's with the sort of unlisted code 43999. That should be changing soon. So one is this: we have this FDA approved kits that are available from Boston Scientific. Boston Scientific's bought Apollo Endosurgery. And we currently have a HCPCS code. And I don't know how many fellows are really familiar with the coding and the CPT and everything, because I know my fellows are really not very good at it at all. But a HCPCS code is the code that is there is currently covering only facility fee. So Medicare will pay a facility fee for this procedure. They will not pay a physician fee. So if I do it for free on a Medicare patient, the hospital will be very happy. But I'm kind of stuck spending a little over an hour doing this procedure and not getting much for it. Getting an EGD out of it, essentially. There is a CPT code that is expected in the next few years, maybe 2025 or so, that we'll be getting that, and that'll help us get insurance approval and get more patients to get these procedures.
So that was actually one of my questions you just mentioned. How long does this procedure take?
Yeah, it's a good point. I was going to mention it earlier and I forgot to. There's a learning curve. You will start off with doing about 2 hours, 2.5 hours, 3 hours of this procedure. Where these patients are going to be intubated no matter what. We intubate them. We give them anticoagulation, so I give them heparin now. We'll do a heparin injection just as if they're getting a surgical, just for DVT prophylaxis. And then it's about 70 minutes, 70 to 75 minutes is what my typical procedure will go for. I try not to make it much shorter than that. I know there are people who do it 45 minutes, but I feel like you're not really getting enough, you're not putting enough time into it. You're not getting enough bites if you start kind of cutting out and doing it a little bit shorter. But once you've gotten used to it, it shouldn't be much longer than that. It should really get to that level. The big thing is just being comfortable and being quick with the device itself. And because beyond that, it's just a decision of where you want to make your bites. And then having a team, having like a technician who knows how to do this and who works with you. And like the technician is putting the helix in and helix out. So they're grinding the helix in. So I'm putting the helix in and I say, okay, helix in. They're putting the helix in. I'm pulling back the tissue and then I'm making my bite. As soon as I make my bite, they know to just start undoing that helix so that when I kind of exchange, take the needle driver out. By that time, everything is essentially gone out of the tissue, and I don't have to say, okay, helix out, this, that. So you train the people that you're working with so that they're quick. They know that as soon as they start doing a suture, that it needs to be a cinch open and ready for them to go. I'll get the nurses involved. I'll teach the nurses how to do the cinching so that the technician can work on while the cinching is happening. They can work on getting the next suture ready, just so that there isn't a waste of time.
And you mentioned that the learning curve is probably about 50 cases or so.
I think you can do one. So I think we have, we have privileges that are that the numbers are a lot less than that. You need to do some kind of suturing cases of some sorts. I would do simple suturing cases, putting in stents, getting stents sutured in. Small closures, maybe there's a small hole or something. You said, okay, let me close this and see if that works. Marginal ulcers, you can suture those marginal ulcers and close them just to get yourself used to the device a little bit. It takes about 25 to really get yourself comfortable with the device and kind of know what's going on. With a lot of the training that Boston Scientific is now offering, it may not be that many cases. You probably could get away with a lot fewer cases. But when I started as a fellow, there was no training courses. It was essentially you need to work on I messed with it a little bit outside on a model, but essentially you were then doing it in a human, and you're working yourself and getting yourself acclimated with the device.
Sorry for interrupting.
Was that?
There was a recent publication that showed that in people who are proficient in endoscopic suturing, they only need 9 cases, but I think it's an overestimation. If you are in your learning curve, you need much more. 20, 25.
Yeah, you need a lot more.
Much more realistic.
If you're but I still will stick to that number to really get yourself to know things. You can easily, like I said, with the amount of training they now do with Boston Scientific and Apollo are doing, you can get away with a lot fewer. Probably by 5 to 10 cases. You're like you're saying 9 cases, but you're still going to get yourself into trouble. You're not going to be able to troubleshoot and figure out what to do with the device once it messes up. Everything can go wrong. The cinch can get stuck. The needle can get bent and you can't get it off. You can't go anything else. The whole device, you can suture the device into the patient because you weren't paying attention and the suture went around the device and now you're cinching it and you've cinched your tower into the patient and you're like, okay, shoot, what do I do now? So there's a lot of things that can get wrong. And those are the kind of things I think that once you get into your sort of 25, maybe more cases, you'll start handling a lot of those without having much of a problems.
But when you started, can you talk about how you were doing it? Like, were you partnering with someone? How did you get started?
So because I did the bariatric fellowship, I had done about 80 suturing cases, mostly revisions, but some also primary procedures in my fellowship already. And so I'm going, and those were mostly difficult purse strings. So I was doing purse string, mostly that. So I had gotten a much better sense of the feel of the device, the feel of the endoscope, and kind of and how it works, and where I can get myself into, where can I access, where can I not access. It also was actually very useful because this device will test your endoscopic skills more than I think anything else. Maybe ERCP will test it a little just as much, but you really need to have good scope skills. And you need to be able to manage your scope and be able to move the scope without touching the endoscope, right? You only have two hands, and you can't hold the scope in a specific position and then go and try to use the handle, because you're going to lose your location. So you really need to be able to straighten the scope out, really get yourself into the right position, and be able to get yourself so that you can kind of suture in the right location. So I think, I think it's people can say, yes, they'll be proficient at 10 cases, but you're still going to continue to get a lot better as you do more and more cases beyond those 10 cases.
I want to bring in the surgeons, Dr. Jain-Spangler and Dr. Dan, if you're able to comment on this. Have you guys done any cases on patients who have had ESGs done? Okay.
Yeah, so I saw there was a question in the comments about revision after an ESG, and we had a lot of patients who had gotten ESGs and then gained their weight back during COVID. So that was kind of a thing. And so I've operated on a few, and because of the fundus sparing nature of the endoscopic sleeve gastroplasty, I often recommend a gastric bypass. I don't have to worry about, so what I found is that a lot of them, the sutures become encapsulated in the mucosa. So it becomes kind of like a webbed effect within the body of the stomach. And going through and digging those out endoscopically and cutting them all out would be difficult. I do a bit of therapeutic and interventional endoscopy, so I'm not unfamiliar with it, but I do know that the morbidity of going and kind of digging out all of those anchors and cutting everything out, it could potentially lead to some complications. And so I, often will counsel the patients, hey, let's not try to go digging all of these things out. I think they naturally will pass on their own at some point in the future. And if you really want a revision and you've gained your weight back, then I've often chosen a gastric bypass for them. And, most of them have been amenable to that. There aren't very many who have been like, I have to have a sleeve. At revision, so the biggest thing I can say is just always stick a scope down and look, and make sure, like, when you're getting ready to staple and you're getting ready to do anything, there's no anchors, there's no cinches, there's no suture, because that's where you're going to get a leak in your staple line. So that's probably the biggest word of advice I have, is to use endoscopy. If you're doing an operative revision of these, use gas, CO2 gas, and not air, so that it'll be resorbed quickly, because you're going to probably do multiple rounds of endoscopy. And then the last thing I would say is, for bariatric fellows, learn how to do this procedure. So no offense, Dr. Abidi, I think this is phenomenal, and you're a very conscientious gastroenterologist, but at the end of the day, we end up taking care of the complications. So learn how to do this and to become a well-rounded surgeon, if this is something that's going to be in our future.
Adrian, are you there? Do you want to comment? Okay, well, he's thinking. Let me ask you, Kunoor. So if you had a patient who had dilation of the stomach and really wanted to have a re-sleeve after having the ESG, is that something that you would consider?
Yeah, absolutely. And I've talked about it with several patients. I'm pretty persuasive. So often I can tell them, like, a gastric bypass really is. So from a metabolic standpoint, if you gain the weight back after an ESG, yes, you had some dilation, et cetera, but also hormonally, maybe a different hormonal profile is going to be better for you as far as continued weight loss is concerned. And it's going to be different with a gastric bypass and a sleeve. So that's one of the conversations that I have. And then the other thing is, if you're going to do a sleeve on these patients, you're going to do your own endoscopy preoperatively. You're going to see where these sutures are. You're going to decide if you need to cut them out. And then so instead of a bougie, I would put an endoscope down as my bougie. And then as I was stapling, I would make sure with every fire that I'm not getting any sutures or any cinches or any remaining anchors or anything like that as I'm making my staple line.
I have prepared patients for surgery. So there were a few patients. There's one patient distinctly remember because she got arrested essentially immediately after she had her gastroplasty, and so she never had any. She was very limited in terms of what she could do and what could eat, and didn't do did well for a little bit, and then lost contact and didn't do very well eventually. And she wanted to get surgery at that point in time, which I do mention is that some of these patients haven't considered surgery before, and so they get the sleeve and then they start they lose the weight, they do well, and then they kind of gain the weight back, which happens, and at that point in time, yes, I can convince them to say, look, you need to consider a surgery at this point in time. Your BMI is 48, you will do well with surgery, and so they will go to surgery. From talking to some of the sort of surgical friends that I have, the bigger thing is to really take out those the cinches are going to be the biggest problem. You cannot go over a cinch. The cinch is a big plastic piece that that's going to cause a problem no matter what. So I do go digging out for some of those cinches and kind of took out pretty much all of them. I think I'm probably one of them either I missed or it had already migrated by itself. And I'll cut any sutures that are visible, and just kind of say, okay, that should prep them pretty good.
All right, great. Well, I think that's.
Julianne, this is Adrian. I'm sorry, I
Oh,
heard you
hey,
calling
yes,
me.
we would
And
welcome your comments
I
right now.
was on, but I'm also heavily invested in the Browns game right now. But I did hear my name, and I want to make sure you knew I was here.
We were just talking about revisions after ESG.
You want me to give my
Yeah,
comment?
would love to
Sure.
hear it. I
So
think the fellows would
I will
appreciate that.
just briefly say that I have not had the pleasure of doing one yet, and I'm sure we all will. I was a bit surprised a few happy hours ago. We had a presentation of a revision after an ESG, and I was just surprised at how much it can affect the extraluminal stomach and the amount of adhesions that you can have. And also, I just think of the sleeve gastrectomy as if you look at the safety profile of the operation, it's going to be very different from the safety profile of the sleeve gastrectomy after those plastic uh, uh, those plastic pieces are left in place and the anatomy is altered. So I'm a little bit concerned about that, but nevertheless, I think just as with every procedure, we will be seeing some patients that will need conversions to other operations. I think it's going to be interesting. Patients need to take that into consideration
Yeah, I
because
put some pictures, Adrian, in the chat. I think that's my average kind of what I see when I go in to do an endoscopy of somebody who's had an ESG that has dilated, and kind of the conversations, why I'm having the conversations that I'm having regarding gastric bypass versus sleeve.
correct. It's exactly. I think we're on the same page. So I will say that that's something that the patient needs to really take into their calculus, especially if they're a younger patient, and an ESG may not be the solution for the next 60 to 70 years of their life. What the revisional operation is going to be like, what their safety profile of that would be, and that's my 2 cents.
Yeah, so I have not, sorry, I'll just say something really quickly. I have not had to do one of these cases, but I'm glad that Adrian brought up the previous happy hour. I would encourage you guys to look at it. It's from last year with Scott Shimpey. Go ahead, Dr. Abidi.
I was gonna say I like the idea of selling a gastric bypass, and I think that does make sense. It's probably the safest way to go about it, and these are patients who have already failed one procedure, so may as well give them the highest chance of being able to lose that weight and keep that weight off.
Yeah, and the meds are making me really think more about how we're picking these procedures for people. So in ESG, hormonally is going to provide a lot of similar things that I think, we haven't done adequate meal stimulation studies or any of the things that we need to do, and we will, like the rodent model you were talking about. But I think doing a laparoscopic sleeve versus a gastric bypass is providing a very different hormonal situation for a patient. And so in my mind, I just think providing the the highest metabolic effect, SADI or DS might be an option, but it's the same pitfalls as with a sleeve. And so I think a gastric bypass, because a lot of these patients are also a lower BMI and are not really brittle diabetics. So often the gastric bypass is just kind of the perfect setup for them, as long as they're going to be compliant and they don't need the things that are going to cause ulcers.
All right, great. We're over time. I would love to continue this conversation, but next month. Dr. Abidi, thank you so much for coming on and talking to us about ESG. Thanks, Dr. Pantelis, Dr. Jain-Spangler, Dr. Dan, thank you so much for your comments. Guys, stay tuned for a couple of weeks. We'll have upcoming seminars. Keep an eye out for emails from us. Happy holidays, guys. Happy New Year's coming up, and we'll see you in 2024. You guys have a good night.
Good night. Thank you.
Thanks, everybody.